All right. So, good morning, everyone. And this is our first of its kind panel discussion, podcast, videocast, whatever you want to call, about a very sticky topic, and that's structural heart disease imaging in general and training for structural heart disease imaging in particular. So, structural heart disease imaging is kind of a new specialty, as we'll discuss with the panelists that we have on board today. And then what is still undecided is who can perform structural heart disease imaging. It is the cardiologist or the cardiac anesthesiologist, and either one of them do they need specific training or the imaging skills that they acquire during their routine or regular accredited fellowships are sufficient to have enough I would say expertise to go ahead and perform this procedural guidance. So, for this reason, we have today gathered a bunch of experts, which range from our recently graduated structural heart disease fellow, Dr. Kendra Derry,
Hi.
Dr. Sohail Mahboobi from Lay Clinic, who is the director of cardiac anesthesia as well as residency program director,
Good to be
Dr.
here.
Ruma Bose, who is the fellowship program director at Beth Israel Deaconess Medical Center, and Dr. Aaron Sharkey, who's our co-director of our Center for Education, Research, and Technology and Innovation, and is also structural heart disease imager par excellence. Just to give you a perspective, the only two people who are well slept here are Kendra and myself. Aaron is post call from an in-house call. Ruma is on heart call, and Suhail, you're also in the hospital right now.
I'm
I'll
working right
clarify I'm also on heart call.
Okay, you're on call. So I'm the only one who is essentially just lounging over here. So thank you very much, first of all, for spending some quality time with me on Saturday and answering these questions. So I have already emailed you the questions, some of the ones that so but we'll digress left and right based on this thing. So my first question would be to Dr. Ruma Bose. She has published extensively regarding curriculum for structural heart disease imaging, the training requirements, and that is structural heart disease imaging is defined as providing procedural guidance for non-ischemic interventions for structural problems on the valves and the ventricles. Do you think it should be a specialized training beyond what we do during cardiac anesthesia fellowships, or should it be part of those cardiac anesthesia fellowship training?
So thank you for having me on the panel, Feroz. And yes, short answer is yes. There is a requirement for a specialized training in this field. Having gone through the process myself, just having a baseline of ACTA, peri-op echocardiographic training is not enough. There's a learning curve to performing structural heart imaging. And the question remains whether that can be incorporated into our ACTO fellowship or not. Or at this moment, the way the arena is, we definitely need an extra focus training in this field.
So to follow up on this question, you have recently completed a survey of the Society of Cardiovascular Anesthesiologists of regarding people's involvement in structural heart disease imaging. What did you find out? How many programs actually are involved in this thing?
So the interest is there across the board. People wanted to step into this arena and take our expertise into a structural heart imaging field. The problem was that the field is divided between cardiac anesthesiologists and cardiologists who are also performing this field. So there's a very big variability in the offerings at each institution. So we are basically, this survey was a fact-finding mission to see where the training can be incorporated, what are our resources available, how the curriculum should be designed. So we will be publishing the results of that survey very soon. But overall, the sentiment was that yes, there is an interest in this in structural heart imaging, and extra training is required. The fellowship should, if possible, incorporate it into their curriculum, and there is a job advantage, hiring advantage to people who have experience in this field.
So I'll follow up this question with Suhail. Suhail, I know you're involved with the American Board of Anesthesiology. You have been a director of cardiac anesthesia and residency program director. So you have a good grasp of what the training requirements of accreditation are. Do you think if you were to mandate structural heart disease imaging during an accredited cardiac anesthesia fellowship, would all programs be available? Would be able to provide this structural heart disease imaging training for them?
Well, thank you, Feroz, for having me today. That's a very interesting question. I believe it will be a challenge currently at this time because not a lot of centers who are providing training in cardiac anesthesiology have either enough cases in number or variety to be offered to cardiac anesthesia fellow. And also, as Ruma mentioned correctly, we have our structural heart disease playground is being shared with cardiac cardiologists also, and their fellows have their requirements. So it will be a challenge. It will take some time. Maybe in next decade, we'll see ourselves in a situation where the structural heart disease cases are more commonly being done in more facilities and more programs. And the cardiologist, like happen in cardiac anesthesia, that does not have either time or interest to provide services in the structural heart disease cases. But currently, at this current moment, we may not find a lot of programs prepared enough to offer this training for cardiac anesthesia fellows.
So that will brings me to Kendra, who has recently completed a structural heart disease imaging fellowship with us, and she trained herself initially at the at in Ottawa Heart Institute, right, Kendra? That's what it is.
Yeah, that's correct.
So, do you think your cardiac anesthesia training prepared you enough to perform structural heart disease imaging, or you gained sufficient knowledge and experience from structural heart disease imaging fellowship? Please explain.
Yeah, so, this is an interesting conversation. I was actually pretty fortunate in my cardiac anesthesia fellowship to have quite reasonable exposure. There's only two fellows, and they do 2 days a week of structural heart imaging. So usually it'd be once a week that I would be exposed to the structural heart cases. And I did leave that fellowship feeling like I had a good foundation in structural heart imaging to be able to provide imaging for those procedures at my next place of employment. But it became apparent to me pretty quickly that it was a bit of one of those scenarios like you don't know what you don't know. And while I had a lot of exposure to mitral clips, there was many other structural heart procedures that I didn't have quite the volume of exposure to make me feel confident in providing imaging and providing feedback to the proceduralist about different decision making, which is a part of the procedure as well. So I felt really fortunate to have this opportunity to come to Boston to have the dedicated structural heart imaging fellowship where, I had exposure to a lot of volume of cases as well as a variety of cases. And it really became apparent to me that even though I felt I had reasonable exposure in my initial cardiac anesthesia fellowship, I still had a lot to learn. That was a good foundation of skills, but I needed to have more exposure to enhance those skills to really be a contributing member of the structural heart imaging team.
Excellent. So, Aiden, you've also been heavily involved in education and development of curricula and innovations in different kinds of, techniques to improve competency and proficiency. So, do you think there are enough cases to go around to train all the cardiac anesthesiologists at this moment in time? And I'll follow up that with another question.
I think this is very center specific answer. I think there needs to be a minimum threshold for fellows to do cases to become proficient in all of these cases, and especially with the ever evolving mix of cases that are coming on board under the umbrella of structural heart disease. So I can't speak for every center, but certainly in our center, there is an adequate number of cases for a fellow to be exposed to a wide variety of pathologies over 6 months to become proficiently trained in a 6-month period. Yes.
So, do you think there's room for some innovations like structural heart disease simulators, workshops, or hands-on sessions at specific locations where some form of competence or some kind of proficiency could be at least imparted to people who want to get involved in structural heart disease imaging?
Absolutely. I think there's the need is there and the technology is also there. So the mantra of, see one, do one, teach one is not kind of the way it should be done. We should be training fellows in the education lab prior to stepping into the structural heart room. We have simulators, and not alone simulators for doing echo, but we have structural heart disease specific simulators that incorporate both the proceduralist and the echocardiographer, because not alone is the value in obtaining the images, but it's also the communication which is paramount in the structural heart room, the communication between the interventionalist, but also between the echocardiographer in directing the imaging and the procedure. And this can be done in the safe environment of a education lab with a simulator. And this is something we have to practice this image acquisition, this communication, and this is also helpful for the proceduralists because this communication is a two-way stream. So it's helpful for everybody to get involved with this prior to stepping into the structural heart disease room.
So the follow-up on this is that the recent expert consensus that was published regarding, classifying and identifying a structural heart disease imager, the number of cases you need to have done. So the requirements are that you need to be a level 2 echocardiographer, which means your competence has been verified by an independent body, that being National Board of Echocardiography. And the number of cases that you need to do to be qualified are pretty exclusionary of majority of the centers, that I would say, because what do you think, Kendra? You've seen that, right? They say something like 50 mitra clips and some ASDs and VSDs. What do you think? Are these requirements exclusionary or too exclusionary or too specific to not being able to classify most programs as structural heart disease imaging programs?
Yeah, it's hard to say because there's quantity, but there's also quality, right? And I also think it might be a little center dependent in what that center is particularly looking for. Say it's a lot of centers might only do mitral cleft. So to have a certain number of ASD closures when that center doesn't even provide that service might not be necessary. Again, I think it comes down to, quantity is definitely important, but also quality. And I think we'll talk about this, coming up, but, our modular approach to the training rather than the all or nothing approach. So I think that would be the most important there.
So thank you very much for bringing it up, because that was my next question to Ruma. What is this modular approach to training in structural heart disease imaging?
Yes, so this is actually one of the guiding principles of our training, which we are trying to imbibe into our curriculum, and that would be the stepwise approach to a global competency. So that means that each competency is divided into smaller mini competencies. And for example, the interatrial septal puncture, globally, it's just crossing this interatrial septum from right to left, but it consists of a lot of mini competencies which would make the final, the end result optimal. So we are actually following that. This approach was published in the paper which was named as the Pitlock Protocol, and now we are coming up with a similar approach to mitra clip, how to break it down into smaller pieces so that we are able to get a mini competency leading up to a global competency.
Okay, so the next question would be let me take Aiden out because it seems to be frozen, and bring him back in again. Does it work, Aiden, now?
Yeah.
Okay, so Kendra, now since you're on the top of it right now, I'll ask you another question that you're right there. So the question is that, do you think 6 months duration for your training was sufficient, or do you think it should be more than 6 months?
So I felt the length of time that the structural heart imaging fellowship definitely was adequate. I don't think it's necessarily length of time. I do think it's the exposure that you have. So we did probably at least 2 days a week of 3 or more cases of structural heart each of those 2 days. So I think that for 6 months would be adequate, as long as you're thinking of number of cases, breadth of variety of cases, and as well as having the simulation and the team-based meetings. That's all important a part of the fellowship as well. So the 6 months, 2+ days a week with multiple cases per day, I felt definitely that was adequate.
So, Hale, a question to you is that now that we have evolving new specialty requiring a new set of skills to be imparted to a lot of people, some of them are in training and some of them are fully qualified, and some are towards the later end of their careers. How do you expect everyone to become proficient? Or is it like the same old days when TE was introduced? Some people who didn't do TE just got disenfranchised, and 3D came, and people who didn't understand 3D got disenfranchised? Or is there a plan to put everyone on board with this training? What do you think?
So definitely there are challenges in that. Not all of us who are already in practice have exposure of structural heart disease from our training. But luckily, there are modalities available like simulation, modules, industry sponsored courses. So in order to train our next generation of fellows, we as providers and teachers, we need to be trained first. Not all the centers have the volume which your center has right now. The volume is not that high at this current moment. So it will take some time. It will take an intentional effort on part of the current practicing anesthesiologist to become a part of a multidisciplinary team, so the cardiology can to be part of that OR structural heart disease echocardiography team, and then you offer to the next generation afterwards. I'm talking about like on a general scale. Most of the centers currently in the country are evolving in this field. They're not.
So you're suggesting create a concentrated nucleus of people who are experts, and then we have a trickle down effect over the time that we'll all learn about it. Is that what you're suggesting?
Or have a curriculum, or have some certain milestones that we can achieve. Attend a course, or attend a seminar, have some sim sessions with the centers who already have adequate training in it and expertise in it.
So a pathway to proficiency, that's what you're taking.
That is correct.
So Aiden, my question to you is that I was part of a discussion in the Society of Cardiovascular Anesthesiologists regarding how do we, create this pathway. One of them was that when we graduate somebody who has done enough of structural heart or met certain milestones, they should be graduated with a special certificate of competence in structural heart disease imaging, which means at this moment in time, that would be a desirable skill. And if you want to go ahead and do something which you didn't acquire, then you have to follow the pathway. Do you think that you are part of the SCA Echo Week also? Do you think symposia like Echo Week and all other CME courses can be a potential solution to this thing?
I think they can be part of the solution. I think, I think you need to have a training in a center that does a lot of these, because there's certain stuff which you can gain from simulation from courses, but there's also a lot of stuff that you just cannot gain from these courses. And I think a lot of that is the real point of care decision making that's involved in structural heart disease imaging that is different from the imaging we do in the cardiac rooms.
That's a great point, by the way.
Making decisions that are, at the time is something that cannot be simulated and something that needs to be achieved doing cases.
Or
So
hands-on exposure, real-time
hands-on exposure. So while these courses do provide a lot of framework, They don't provide everything, but I think they can be incorporated as part of the solution, but they're not all the solution.
So what do you think would be the solution?
What's all the solution is to everyone should come to Beth Israel and do 6 months as a structural heart disease fellowship.
Okay. The number of calls that Kendra did at Beth Israel, I don't think if she comes out with the truth, we may not get many fellows then, right?
But I kind of want to echo just what Aidan's saying, that, you know, you can read about it, you can watch videos, you can watch tutorials, but the real training comes with being there, putting your hands on the echo probe, working through cases, being a part of the decision making. So it's one of those skills that you really need to be present and be in the OR and physically doing the cases. And again, it's just, you know, it's volume and exposure. And so that's where the fellowship really comes to hand.
So Ruma,
But
yeah,
and to add on to that, Kendra, it's we all obtain this very similar images, but it's doing the advanced knobology as the clip is being maneuvered in the left atrium when the interventionalist is asking you a very specific question, and doing the imaging, doing the knobology while taking into account the whole clinical scenario is something that only experience and doing these procedures can. You can only get it at that time.
And like you said, it's a very different skill than the echo that we do in the OR for cardiac surgery. It's it's a different skill set for sure that needs to be learned.
So Ruma, what were you saying?
Yeah, I wanted to add that, yes, the ideal training would be in the OR, taking the time to, become proficient in this. But our problem would be to find the optimum amount of time that we could kind of compress this training into a very high quality experience in the OR. And in that case, what Aidan was saying, that the preclinical phase of preparing for that clinical experience is very important. So if somebody has already mastered their MPR skills, their knobology, and in the sim lab and are well positioned to apply those in the operating room, I think that would help us in cutting short or minimizing the time that is required for hands-on experience.
So to push back on that, and I'll get to Suhail for this one.
Mm-hmm.
That we've been trying to introduce perioperative ultrasound in the anesthesia world for a while, okay, and expecting people to do something voluntarily. Only when American Board of Anesthesiology made it part of the curriculum and part of the OSCE exam that the programs responded by creating, teaching modules and curriculum and things like this, So do you think, Sohail, that would be something to create a certification for structural heart disease imaging so that programs respond to it by being mandated to do something to create a curriculum and enforce it? What do you think?
That's a very interesting question, and that it's going to draw a lot of discussion nationally. As you can imagine, you can well imagine with the cardiothoracic certification coming now, there's already a lot of comments and feedback from different programs. So in short, yes, that will increase the programs to participate and set up the curriculum and have pathways to train fellows, either as a separate fellowship or a part of the current fellowship for the adult cardiac anesthesiology. Definitely, if there is a certification for that, or if there is an ACGME accreditation for that, definitely that will increase this specialty further. On the hindsight, do we want it to be an extra 6 months for a cardiac anesthesia fellowship, or would we like to go in a direction where it will be considered a part of the armamentarium of an adult cardiac anesthesiologist?
But here's the deal: the cardiologists. So sorry to cut you. The cardiologists are very militant about it in suggesting that those skills that you're acquiring during non-invasive cardiac anesthesia fellowship are not sufficient to become structural heart disease imagers. They are very specific about that.
And I will agree with that. And that one of the reasons for that is because of the exposure to the cardiac anesthesia fellows. I know that your center is lucky enough to have a combined interdisciplinary team where the anesthesiologists are a part of the echocardiography team for these procedures, but not most of, more than 90% of the centers in the country they do not have that luxury. It's cardiology led. Still, the cardiology is performing the structural heart disease echocardiograph. Either we make a combined pathway where we can be a part of that team as an anesthesiologist. That will be one of the solutions going forward.
But Kendra, I would like honestly want to ask you one question. Do you think you had to get licensed in Massachusetts, you had to be privileged at our medical center, you had to take a leave of absence for 6 months from your job, move to a different country, from Canada, okay, from Kingston to Boston? But do you think it was significant logistic and fiscal hardship that not most people can bear? What do you think?
Yeah, that's true. I kind of had to evaluate what was important to me and my career going forward and what I was interested in for my career goals. And I felt that that was worthwhile. And I'm, extremely glad that I had this experience and, I would do it again in a heartbeat. Would that be feasible for everyone? Probably not, especially people who may be established in certain cities, who have families and other ties and commitments that they can't, go to another center, another city, another country for 6 months. But I kind of hope by having this conversation that more centers will kind of have this in their cognition that maybe we should start doing this as well, and that there'll be more opportunities maybe closer to home for people that they can go to do these fellowships or extend their current cardiac anesthesia fellowship by 6 months at their major cardiac center. So I think having this extra training, this extra 6 months of a designated structural heart fellowship is important. And at academic centers, we need to kind of think about how we can facilitate this, because it's a conversation, and I don't want to say problem, but something that we're going to keep experiencing as the volume of cases increase and the structural heart imaging extends just from academic tertiary centers to smaller centers, that more and more people are going to have to be involved in providing skilled echocardiography for these procedures. So we'll have to evaluate how we can facilitate that.
So, Ruma, you suggest you had done the survey. So, in your survey, what percentage of community centers were doing, or not major academic medical centers were doing mitral clips?
So I don't have the real numbers in my head right now, but again, the program was completely divided between cardiology and anesthesiology, leaning more towards centers that are run by cardiology rather than anesthesiology. So that was, but as informally, I've been speaking to people, and it seems like more and more centers are interested in doing this. The anesthesiologists are interested in stepping into this arena. So there is definitely a need for this in the global community.
Possibly related to the dollar value of the time you spend in there and what the reimbursement of this thing is.
Exactly.
Well,
Feroz,
that
can I ask?
yes,
To the panel a question, because you have
please.
more experience in that. What was your experience, if you can share, challenges, difficulties making anesthesiology part of the echocardiography team in structural heart disease suites?
Yes, that's a good question. I can tell you this one. So the first, most things in opportunities in life present as challenges, and it is purely that you have to sometimes have, not that I have the vision, but I was trained and worked with people who had the vision to see this thing as an opportunity when the cardiologist starting off hours, as Aidan knows it very well. This most of these cases are, we need to do an emergency mitral clip at 3 p.m. on Wednesday, or at 2 or 2:30 p.m. after I pick up my kids from the school, I'll do an urgent mitral clip or a TAVR. So we recognize that this is an upcoming specialty. So we bent over backwards to accommodate this thing and to be the sole providers of imaging in that field. So initially it seemed and felt like a huge burden, but over the time it has translated into a huge opportunity and a academic and windfall for our medical center, our department, and our division. Aaron, do you think is that the, and if you were to start refusing these off-hour flexibility in scheduling, most centers, that's the reason they lose out on that. What do you think?
Yeah, no, I think as anesthesiologists, we are well positioned to take on these cases, because we're used to working in the operating room environment. We are used to doing, picking up these cases that need to be done off hours. And as Feroz said, it's just getting our foothold in the door by being available, by being accommodating. This is facilitated to them now requesting us to do all these cases
And
all the
other
time.
thing, Suhail, the second part of the question is that whenever some new technology gets introduced, this challenge is faced, like laparoscopic surgery, interventional cardiology, the robotic surgery, and everything. And it's the three levels of commitment that we've written about. Number one is your own personal commitment to teach and train yourself, just like Kendra did. Make an effort to do it. Second is the departmental level, that people, they should recognize that there's an advantage in this skill development. And the third is the societal contribution to it, which means the professional organizations should make it possible for those people who really want to advance their skills and further their careers and enhance their proficiencies, to have workshops and courses and simulations and pathways to those proficiencies. So the hardest thing over here is convincing the people that this is an opportunity, that this is not a challenge, it's an opportunity. And there are people who stood out of TE. I'm old enough to know that when biplane TE imaging was replaced by omniplane, a lot of people gave up TE imaging. And when omniplane 2D imaging was replaced by 3D imaging, a lot of people said, I don't want to deal with 3D, and they stood out this thing. And now this is a similar scenario developing, that now it's structural heart disease imaging. The next one is intracardiac echocardiography. And you will all be again challenged over and over and over again with this one. And it really depends on how motivated you are, how good your department is in recognizing the value of skill development and progression. And third, how the society responds to it. That would be my answer to that question.
Thank
And
you.
also, yes.
Great insight. Thank you.
So I think we are reached the limit of our time today. Honestly, great discussion, but we should continue on with more panelists next time, because the next one, which Kendra, you have another project for you, and that is to look at the billing for structural heart disease imaging. I mean, this is a total black box that no one has so far figured it out, and it's pretty controversial, pretty sticky, and pretty debatable, and is not sorted out whether what's the best method of billing for structural heart diseases. And I will try to invite more people from other centers and other geographical locations to participate in that. Well, thank you very much for you all for spending some good time regarding. We haven't solved the problem of training for structural heart disease imaging, but we did bring up some good points over here. Thank you very much, you all, and we shall see you soon in a couple of weeks.
Thank
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 you
you,
you so
so
everyone.
much.
much.
Thanks.
Thank
Bye.
you.
Thank
Bye.
you. Thank you, guys.